All right, our next speaker is Ayesha Mahmud. She's an assistant professor at UC Berkeley.
Thank you so much, Katia. I'm really bummed I'm not there, and having to do this virtually, but thanks for the opportunity to present some of this preliminary work. So I'm going to be talking about some work we've been doing over the past few months using some contact data that we've been collecting. So I'm going to start by just giving some brief overview about this contact data in case it's interesting to folks, and there's a lot of data there that we're hoping other folks would be able to use in their modeling work. So I'll talk a little bit about our contact data, and then I'll talk more specifically about this project looking at evaluating vaccine prioritization strategies. And I just want to start off and say that this has really been a big team effort, and just a few folks who I wanted to name up front. A lot of this work I'll talk about today is led by Ethan Rubinoff, who's a PhD student in demography at Berkeley, and my collaborator and colleague here at UC Berkeley, Dennis Feehan, who I started the contact survey project with. And there's a few other grad students, Taylor Chin in Harvard, and Casey Breen, who's also been doing a lot of work with this contact data. And a really shameless plug is that Taylor is going to talk tomorrow about some other really wonderful work from Bangladesh and mobility. But if you're interested in this contact data, you can find Taylor at the conference, and you can ask her all your burning questions and how to access this data and so on. Okay, so I'm going to talk a little bit about this need for contact data for modeling. I think in this audience, I don't really have to spend much time on this, but we have evidence specifically from the Polymod study in Europe led by Masong et al. That contact patterns are highly assortative in human populations. So if we look at these contact matrices, this is just plotting age of participants against the age of their contact. We see these very clear patterns, lots of mixing along the diagonal, and then we see signatures of parents mixing with children, grandparents mixing with their grandchildren, and so on. And we see sort of the highest amount of contact happening in the school-age children, which has been shown to be an important driver for many respiratory pathogens, including flu and so on. So we started a contact project in Berkeley when at the start of the pandemic. So the first round of our survey, which we called BICS, or the Berkeley Interpersonal Contact Study, we did the first round right as soon as the lockdown started here in Berkeley, and we just sort of thought that we would try and put together a very quick survey to try and understand what was happening with contact in the U.S. And part of this was motivated by the fact that we have such rich data from Europe looking at contact patterns, but unfortunately we don't have a great deal of data from the U.S. looking at either pre-pandemic or during the pandemic contact patterns, and we know that these are important for the transmission dynamics of SARS-CoV-2, but also other respiratory pathogens. So we've been collecting several waves of this data. We so far are up to 6 waves of data. We kind of have taken a pause in collecting the data for about the last 6 months or so, but we do have data until fall of last year. So we asked people about their interpersonal contact in these surveys. They're very similar to the Polymod questions. So we actually spoke with some of the folks who designed Polymod and some of the other surveys in Europe to try and keep the language pretty similar in the hopes that we can compare this data across countries. So we've been collecting data from a national sample. So that's about 1,300 to 1,500 per wave. And then we have city-specific samples that in some ways we chose based on where collaborators sort of wanted more data on. We had some, folks in the various public health departments who reached out to us early on in the pandemic and wanted contact data. And so we started collecting some of these city samples. So there's not really any strong reasoning behind why we chose these cities. We might add more cities in the future. So this is just to give you a sense of what our data looks like. And this is what the contact matrix looks like. So the first column here is showing contact patterns over time. And you can clearly see as we're going from very early in the pandemic, so this is going from March 2020 to September 2020, you can already see contact patterns start to increase. So the more yellow greenish colors are indicating higher levels of contact. I think we'll ignore the middle column here. That's just comparing to some baseline pre-pandemic data that we had. And then the final column is just showing contacts by age group. So you can see that sort of the 25 to 45 age groups are really the ones where we see sort of the largest drop in contacts compared to the pre-pandemic baseline. So the lighter blue colors, the lighter blue bars are showing the pre-pandemic baselines. And you can see that contacts really dropped for those groups, which normally we see pretty high levels of contact. And then school-age children as well. School-age children as well, we saw a pretty big drop. The sort of other interesting pattern we saw in our data is when we looked at differentials by race and ethnicity, we saw pretty clear increases over time for almost all racial and ethnic groups. So the legend didn't quite show up here, but these colors, in the plot on the left is showing the different waves of the pandemic. So the green is wave 0, and we're going forward in time. So you can see pretty much what we see in the overall sample as we go forward in time, we're seeing an increase in contacts across all groups, but there's clear differences in levels of non-household contacts across race and ethnicity. And then if you look at the plot on the right, you can see the differences broken down by gender and by age group. So we, in general, in our survey, males report higher levels of contact. And we also see this generally higher levels of contact in the 25 to 45 age group compared to children and the elderly. And sort of the other interesting thing that we noticed in our data is that, again, over time, we saw this increase in contact in most settings, but particularly in the work setting. And this is sort of, not surprising to anyone. This is the reopening of workplaces and the reopening of the economy. And we see this increase in contacts happening over time, but particularly in workplaces. So we can see that the pink bar, which is in September of 2020, already by September of 2020, we can see a pretty sharp increase in contacts in workplaces. And so when we put all of this together, we started to think a little bit about what workplace contacts might look like. And this is work being led by Ethan Rubinoff. He's a PhD student here. And Ethan designed a set of, a few set of questions that we added to our survey in the final round to ask more about workplace contacts. So he added some questions about, the number of contacts people were having in the workplace versus in other places, whether those contacts were masked, the duration of those contacts, whether they were happening in indoor or outdoor settings, and just a whole host of questions try and understand sort of the types of contacts that were happening in workplaces. And he was sort of interested in trying to understand the sort of the types of contacts that were happening in workplaces, but also the understand, the people's ability to work from home or to be able to shelter in place probably varied by demographic characteristics. So he was kind of interested in digging into that a little bit more. So once we started asking these questions about employment status, we were actually able to create these contact matrices both by age and employment status. So this is showing Again, the same contact matrices, but now we structured these a little bit differently. So we've just split adults into what we're calling low contact and high contact. So low contact adults are ones who are generally in our survey reporting that they're mostly working from home and have pretty low levels of workplace contacts. And then high contact adults, the adult HC, are the ones who are working in person. And we do ask questions about whether they're in essential work occupations, whether they're frontline healthcare workers, and so on. So we have a lot of detailed information on these workers that we actually haven't had much time to delve into, but there is a lot of information that we collect on these high contact workers. So we're able to create these contact matrices, and you can clearly see the adult high contact workers are having much higher levels of contact, not just with themselves, but also if you look sort of at their contacts with the other groups, they're also in pretty high contacts with the other groups as well. And so this has important implications for thinking about vaccine prioritization strategies, particularly if we're thinking about the indirect protection offered by the vaccine and trying to think about reducing not just mortality, which is one of the key goals of vaccination, but also thinking about reducing overall infection burden. So just very briefly, there's been, this sort of debate over vaccine prioritization in the US has really been defined by two very sharp disparities in mortality. One is this very strong, disparity we see in COVID-19 mortality by age, where we see adults over 65 have a much higher risk of mortality given infection compared to all other age groups. The other story that's really shaped this debate is looking at differences in COVID-19 exposure and risk of mortality across different racial and ethnic groups. And a lot of the sort of conversation around this has been about thinking about essential workers and the distribution, the demographic distribution of the populations that are employed in this essential worker occupations. And so one of the early debates was centered around thinking about whether when we prioritize high-risk adults, which is an obvious strategy for reducing mortality. In some ways, there's a racial equity debate there because of the demographics of the older population in the U.S. And so, a strategy that prioritizes older adults initially gives more doses or proportionally more doses to white Americans compared to others, whereas a strategy that targets those who are unable to work from home, those who are in essential worker positions, has a more equitable distribution across all races because minorities are overrepresented often in those occupations. And so one of the questions we were interested in is, since we have data on these high contact workers, we wanted to think a little bit about evaluating vaccination strategies by age and employment status. So we consider 5 different strategies. We consider prioritizing adults over age 65, and we consider prioritizing high contact workers. And we have variations of the strategy where we split vaccinations between adults and high contact workers. And we have these tiered rollouts where we first prioritize one group and then focus on the second sort of high risk group. And again, this idea here is to think a little bit about the sort of both the direct and indirect effects of vaccination. So, I think prioritizing adults over age 65, there's been numerous studies showing that to reduce mortality, it makes most sense to prioritize adults over age 65, given that we know that this mortality increases so starkly as we age. And so a strategy that prioritizes adults over age 65 likely makes the most sense for reducing mortality. But we wanted to think a little bit about some of the indirect effects and look at whether different prioritization strategies might be beneficial for reducing not just the total mortality burden, but also thinking about total clinical infections. So we use a pretty simple age and employment structured SEIR framework, and we model an initial rollout of a 2-dose leaky vaccine starting in January 2021, and then we also look at the impact of a booster dose during a hypothetical subsequent outbreak of a novel variant. So in general, our results agree with what other studies have found in terms of prioritizing seniors averts the most deaths. We do, however, find that if you prioritize high contact workers, it does seem to avert the most clinical infections. And I sort of have a caveat here that this is true in most cases. So this is a little bit dependent on some of the model parameters that we use. And because initially, at least, there was a great deal of uncertainty about some of these sort of parameter values and efficacy of the vaccine, and probability of mortality given vaccination and so on. So there's some sensitivity in sort of how the outcomes relate to the strategies. But in general, across most of our simulations and choice of parameter values, we do find that prioritizing high contact workers does avert the most clinical infections, but prioritizing seniors across almost all parameter combinations averts the most deaths. So even given the high contact of adults in-person work and the fact that they are having high contact not just with other adults but across other age groups, the mortality profile of COVID is so stark that those indirect effects are not large enough to favor a strategy where you prioritize those high contact workers. And then the last thing we've done a little bit of work on is thinking about what parameters might actually affect these outcomes. And so the two things that seem to be the most important is one is thinking about the timing of vaccination, and the other is thinking about the R naught, particularly if we're considering a novel variant where we might have perhaps a more transmissible variant, and the strategies we might want to employ. So in particular, in terms of R naught, what we find is that for higher values of R naught, we actually see that the relative effectiveness of prioritizing high contact workers for reducing clinical infections is actually reduced, which is a little bit counterintuitive to what we had thought. But this is primarily because the high contact individuals are the ones who acquire the infection the earliest in the epidemic. And so if the timing of your vaccination is such that you're not able to cover most of them in time, what we find is that in very high R naught settings, most of these high contact workers have actually already gotten COVID before the vaccination campaign has had a chance to catch up and vaccinate. And so it's sort of a slightly counterintuitive result. And then I know I'm a little bit over time, so I'll just, I think, mostly skip this, but this is just showing that our results are pretty sensitive to, our choice of parameters for how effective the vaccine is, as we might expect, and also the some of the parameter choices that describe the epidemiology of the virus. And so in summary, we think that this contact data can help us understand some of the disparities in the risk of acquiring and transmitting infections across demographic groups. We have many waves of data that we've had no time to analyze. So if there's students and other folks in the audience, looking for an interesting project, you should please reach out to us. And we have some data that we've already made publicly available, but we're a pretty small team and haven't quite even gotten around to cleaning all of the data. So we'd love to share the contact data with you. We do find that as we would expect, the prioritizing seniors does avert the most deaths, but there is some value in prioritizing high contact workers in terms of averting the most clinical infections. And there's many open questions that we're sort of looking into. specifically the impact of prioritizing strategies on differential mortality burden by race and ethnicity, and thinking about the impact of vaccine hesitancy for both primary and booster doses. And we do ask questions about some of that in our survey, and it would be an obvious sort of next step to look at some of those things. And with that, I'll just acknowledge our funding source, and our initial paper on this, just describing the survey, is the link is there, and that link will also provide you the first 3 waves of contact data. So thanks for listening.